Welcome, everyone. My name is Erin Biesinger, and it is my honor to introduce our speaker today. Annie Goldsmith is a registered dietitian and the founder and owner of Second Breakfast Nutrition, which is here in Charlotte, North Carolina. She holds an undergraduate degree from the University of Rochester in brain and cognitive science and attended Winthrop University for her graduate work in human nutrition. Her educational and professional trajectory has always been guided by a strong curiosity about how biology and psychology interact to inform our human experiences. She worked in neuroscience research labs at New York University and Davidson College before pursuing a career in nutrition. She has experience treating eating disorders at a variety of different levels of care, and she opened her outpatient care group practice here in 2015 with a focus on weight-inclusive care. She's presented on weight-inclusive and trauma-informed care at national and regional conferences, and she currently holds a position on the executive committee of the Eating Disorders Special Interest Board within the ISSTD and a faculty position with the Embodied Recovery Institute. She's an advocate for inclusion, equity, and justice. And on a personal note, and most importantly for her credentials, she was my dietitian several years ago, and the first person to introduce me to many of the concepts that guide my own personal life and definitely my professional work. So I'm very excited to introduce our speaker today, Annie Goldsmith.
Thank you for that lovely introduction. I'm so excited to be here. Sorry if I'm a little stuffed up. I took like 2 COVID tests and just have a head cold. I'm thrilled to be here to talk about this topic that is near and dear to my heart, which is how we understand the research and the science of nutrition, weight, and health, because it is a little more complicated than I think we are kind of led to believe at first glance. So let's kind of get into it. Here's the outline for the talk today. So the first part is just going to be looking at what I've called, the trouble with nutrition, health, and weight research. You can decide if after the talk you agree or not that there's trouble. And we're going to be exploring study design and study conclusions with a critical lens. Critical doesn't have to mean I'm coming at it from like an adversarial place. It's really like, how do we hold with genuine curiosity and critical thinking skills about what we are looking at when we're interpreting research and data. And then if it had been 5 years ago, I would have stopped the talk there, but I can't because of the explosion in the media and in healthcare of these new class of drugs, the GLP-1 agonists. I think the name we're all familiar with is Ozempic or semaglutide. And we're going to be talking a little bit about how that's changed some of the discourse and conversation and also impacts in the healthcare space. All right, so I wanted to start our talk just by, I just kind of Googled some headlines, and I think we see these kind of headlines all the time, right? Morning workouts may be better for weight loss, study finds. And then we have this other study that says exercising at night will give you better results. It's like, okay, vegan diet can help overweight people shed pounds, but then a ketogenic diet, which tends to be very high in protein and meat, to lose weight and fight metabolic disease, and it's evidence-based, right? So it's like we're inundated with these messages in the media about here's, the new study that says this, this, and this, and we should all be doing this thing, but it's often contradictory. And so how are we making sense of these headlines when we get into, well, what's actually happening in the research and the primary source data? And so that's what we're going to start with, just kind of exploring this research with the critical lens. And so to start off, I was kind of thinking, okay, well, what are kind of the 3 foundational premises or assumptions that often researchers are making going into a research study? When we read the introduction, it's like, we know that obesity, in quotations, is a public health crisis. I will be using the O word today in my talk. It's not a word I use in my clinical practice. I tend to use the word fat larger body size to refer to folks who live in larger bodies. However, obesity is still the word that's used in the research space, but it is a word that's problematic for many reasons, and so I'm just sort of naming that about, a note about language. So anyway, when we think about the assumptions that are often going into studies, this assumption that obesity is a public health crisis, an assumption that safe, sustained weight loss is possible for a large portion of the population, right? It's just about what's the best way to do it. And then an assumption that if people lose weight, they're going to be healthier. And so these are the things that we're going to explore today and just kind of say, hey, well, what do we think about these foundational premises? Do they kind of hold up? So we're going to start with this idea that quote unquote obesity is a public health crisis, okay? And so in order to do that, I'm going to talk through this concept that is foundational in research methods. I'm guessing many of you are familiar with this idea that correlation is not causation. In fact, I'm sure, is this like familiar for y'all? Okay. All right. So I'm just going to walk us through an example because it's kind of fun and for anybody who needs a little bit more of a concrete reminder of what we mean when we say correlation is not causation. So, all right. We know that ice cream consumption is correlated with drowning, okay? And so we can ask the question, well, why do we see this relationship? When ice cream consumption per capita goes up, more people drown. When ice cream consumption goes down, less people drown. Do we think that eating ice cream causes people to drown? I'm seeing shaking head. Why might we see this association? Yes.
Because ice cream consumption and swimming happen during the summer.
Because ice cream consumption and swimming happen during the summer, right? So in, from a research method standpoint or scientific theory, it's like, okay, so there's a third variable, there's a confounding variable that can account for the relationship between these two things, but those two things are not causally related, right? So that makes sense. So we can take this concept and we can apply it to weight and health research, right? Because the assumption is that being at a higher weight causes poorer health experiences and outcomes, right? However, studies that examine weight and health do not account for many of these kind of sunshine variables, right? The confounding variables. And there's a lot of evidence to suggest that many other things affect health and weight independently, but in a relationship that is correlational, right? And so you guys can kind of look at these. There's quite a few, but we're going to focus on two today just, for this talk. And the first one we're going to look at is socioeconomic status and access to resources. Okay, I got excited about the animation. All right. And so we're going to talk about the social determinants of health. So I know there's a few different, areas of study represented in the students who are watching this, but I believe some of y'all are from public health. This is a really important concept in public health, and I'll just read it. So what are the social determinants of health? Social determinants of health are the non-medical factors that influence health outcomes. They're conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. These forces and systems include economic policies and systems, development agendas, social norms, social policies, racism, climate change, and political systems, right? So many things that are not about individual health factors impact individual health and health on a population level, right? And so what are some of these factors? Economic stability, right? The ability to get medical care, to pay rent, income, the conditions in which people are living, right? So do people have safe housing, transportation, safe places to move and play? Education, of course, food, right? That's going to impact health. If people have access to enough food at all, if there's access to a variety of nutritious foods, right? Or are people living in food deserts? And then, what's people's community engagement and social support? We know that social isolation has huge impacts for health, as well as stress. Stress impacts, how cortisol responds in the body. It can impact all of these hormone systems and can lead to metabolic syndrome, insulin resistance. There's a lot of research on this. And so, these are all factors that can have impacts on both health and people's weight as well. And so, and this matters because, you know, what we are, well, this says on the bottom of the slide, right? The cause of the health risk is what we target for treatment. And, you know, I think it tends to be easier to say, okay, you as an individual need to, this is an individual problem, so you fix yourself, versus like, oh, maybe we have a lot of really big systemic issues that need to be looked at. That's a much harder problem to solve. And so I think often the individual can sometimes bear the brunt of what is really a systemic problem. So we are now going to look at one other potential confounding variable when we look at the relationship between weight and health, which is the experience of weight, stigma, and discrimination within the healthcare system for folks who live in larger bodies. Okay. So take a moment to look at the cartoon. It is funny because it's so ridiculous. However, what is not funny is that it is based on very, very real experiences of people who live in larger bodies going to the doctor for something that has absolutely nothing to do with weight, and having weight be sometimes the entire focus of the meeting, of the medical appointment, as well as all of the assumptions and biases and stereotypes that come with, you know, how we are conditioned to believe that people in larger bodies behave, okay? And so what ends up happening is that there's a few things that happen. One is people will avoid going to the doctor. This is something I've seen in my own clinical practice. And sometimes the work I do with folks is just like, literally, I'm like their kind of coach, like coaching them through the medical system and how to advocate for themselves within really fat-phobic systems. Because so what we find is that patients in larger bodies are less likely to engage in preventative healthcare and age-appropriate screenings, and may avoid seeking care at symptom onset of, you know, something pops up, because they know they're going to go experience negative attitudes and disrespectful treatment from medical providers. Often medical equipment is not designed to accommodate diverse range of body sizes, so people can't get the testing they need anyways, and often experience unsolicited recommendations to lose weight, which can be really demoralizing and even traumatizing. And so it's like the cost benefit analysis does not really come out in the favor of going to the doctor for a lot of folks. And then another way that weight stigma in the medical system can impact people is through misdiagnosis. And many of you may know the story of your professor, Dr. Basinger, but this was an experience that she had where there was a symptom that occurred, and basically her doctors wrote it off as just, you know, oh, the way you're feeling is because of your body size, and oh, you know, that, you know, lump is just because you have excess fat tissue, right? And so what she needed in order to get care, it wasn't taken seriously, and there was a delayed diagnosis, which, you know, can have huge, devastating consequences. All right. So that kind of brings us to the end of that section, looking at this idea of, you know, quote unquote, obesity being a health crisis. And again, this is an assumption a lot of researchers go into their research with. And so how do we, you know, read studies and say, okay, well, what variables weren't accounted for in this study that could have had an impact that were not considered, right? And then that's impacting how people are interpreting the results. Okay, is it you know, body size, it's a public health crisis, or some of these other factors that can impact both body size and health status? Okay. So next, we're going to look at this foundational assumption that safe, sustained weight loss is even possible, right? In the United States, we have put billions of dollars into the assumption that this is possible if people just try hard enough. So there was a set of researchers, this study was called The Challenge of Keeping It Off, a descriptive, systematic review of high-quality follow-up studies of obesity treatments. Basically, what these researchers tried to do is say, okay, let's look at these studies who have looked at weight loss, you know, intervention, and how do they hold up? Like, in the most rigorous interventions that we can find in the data, does it lead to long-term sustained weight loss? And you'll notice there's only, I think, I don't know how many studies even looked at in this research, because so many weight loss studies are not what we might consider high quality. A huge portion of them are simply not long enough to get any useful information out of. So what we know, and this data demonstrates that, is that there's a real predictable trajectory to weight loss and weight regain. And that usually within the first 6 months to a year is when we see the most weight loss. And then over the next, 3 to 5 years or 2 to 5 years is when weight is regained, sometimes more slowly, sometimes more quickly, depending on the intervention. But there is no studies, well, outside of the Ozempic stuff, which we're going to get to, that look at just behavioral interventions for weight loss that show sustained weight loss within the entire study group. And so if you see one that does claim to show that, look at the duration of the study. It's often 3 to 6 months. Or there's other things about the study that just make it so, maybe the N is really small, or they haven't accounted for dropouts. So like when you're looking at this data, get really curious about, would I consider this a high quality study that really holds up to the rigors of the scientific method? In the study that these researchers identified, pretty much across the board, weight is regained over time, which is the pattern we see the best statistics we have is that what's going to happen for about 95% of people who pursue behavioral weight loss interventions. Yeah, you had a question.
So I've done a study on fat research, and so one of the things that I found out was that, as you said, weight doesn't stay off. And do you think that's because we aren't encouraging people to like stick to their diets, or do you think that it's just because we're not supporting the people to keep the weight off / the way our systems are like just doesn't want it to actually stay off?
Yeah, that's a really good question. So the question was, for folks who may not have heard it, what might account for this? Is it the fact that we aren't supporting people enough in long term in the weight loss interventions, or is it the fact that something in our bodies are kind of fighting this? And I think that, well, there's a few things. One is, what it takes to pursue intentional weight loss is to put the body in an energy deficit, right? To take in less calories than you need to essentially sustain life. And that to the body is an inherent threat, right? And there is a lot of research that shows us that when we do that, the first thing our bodies are going to do is slow down our metabolic rate, but that's not a failing of the body. It's actually an incredibly adaptive thing that we do to survive famines, which is, all of us on this earth are descendants of people who at some point in human history have survived famines, right? And so it is really smart for bodies to learn how to hang on to every, bit of energy that we get when we think that that resource is going to be scarce, right? And instead of that being sort of like, wow, bodies are amazing, it's like, oh, wow, how do we figure out how to work around this, survival adaptation? Weight loss is usually a bad sign. Like unintentional, like if I have a client come in and they've experienced a lot of unintentional weight loss and we can't figure out why, the first thing I'm like is go to your doctor, because that could be a sign of cancer, or, oh, maybe we're looking at depression or an eating disorder. Like the first thing that comes up for me is red flags. So we can look at one more graph here. So this data is from the Diabetes Prevention Program research, which was done a while back. Is anyone familiar with the Diabetes Prevention Program? I don't know that I don't know how much it's still being done. When I worked in a hospital, I don't know, 7 or 8 years ago, or maybe longer, like diabetes prevention program was like all over the place. I ran one of these before I, came into the light. But basically, I think what's really interesting about the data, there's actually 10 years of long-term data, so it's interesting to look at. It's the same trajectory. So the purple purple are the people who had the lifestyle interventions. Again, 6 months to a year, lose a bunch of weight, and then over time it comes back. And to answer your question about, was there a support? These people were incredibly supported, way more artificially than we would ever see in like the real world. I mean, they had free access to, nutrition coaching and counseling and social support and all this stuff. And still, the weight was regained. There's a couple things about this that's really interesting to me. So the purple box or the maroon boxes just had metformin as an intervention. This was a study that was done for people who had like, I think pre-diabetes, and it was like, how do we prevent the onset of diabetes? So one group had a lifestyle intervention, one group had a metformin intervention, which is a diabetes medication. And then one group just was, on a wait list, placebo. And even though weight was regained in the intervention group, they still managed to stave off the onset of diabetes longer compared to the control group. And so the question becomes, okay, well, why, if they regain the weight, would they still be able to delay onset of diabetes? It's like, well, they still were exercising more, increasing consumption of fruits and vegetables. So it's like, we can start to see that, health behavior or health outcomes can change through health behavior, even in the absence of sustained weight loss, right? So we can start to decouple health behaviors and body size. The other thing I think is really interesting about this graph, which is kind of a side note, but I think it speaks to some of the unintentional harms that may happen when we think we're doing something. When we think of weight loss as like, this is just, it's a net benefit, right, for people to pursue weight loss. So what they've done here is they split these groups up into age. So this is all the participants up at the top, then the younger folks, 25 to 44 in the middle, and then 60 years and up. I don't know what happened to the 50 something year olds, but whatever. I guess they're all grouped in here, are kind of down here at the bottom. And interestingly, these guys really gain all the way back and kind of like above baseline, right? And then the older folks, they don't regain all the weight, but actually the placebo group kind of comes down and loses some weight too. So what we know just about bodies and aging is that as we get older, we undergo a process called sarcopenia, which is the loss of lean body mass. That is what accounts for older folks maybe being more frail, having more breaks, falls, that kind of thing. So they did not look at body composition in this study, but I look at these results and I get really curious. I'm like, did this intervention actually lead to the loss of lean body mass in these older adults that then never was regained and potentially like lead to more harm in the long run, right? That's just a pure speculation, but I think it's just interesting to think about. And I think as we are thinking about, this area of weight science and weight research, we have to remember this is not there's costs and benefits potentially. And I don't think we do a very good job of considering what all of the potential risks and costs may be. Okay. So we looked at this idea and got curious about, go ahead.
It's gonna go back to like the challenge of keeping it off. I was wondering, have there ever been like studies done on how the initial weight might affect how difficult it is to keep off like the weight loss, or how difficult it is to lose weight in the first place?
Say more. Yeah, I'm just clicking.
Like how the initial starting rate, how it's like people who maybe weigh more. Is there any like kind of research on how difficult it is to lose weight, and then how difficult it is to keep that weight off? Like
depending on where someone is along the weight spectrum starting. Not that I'm aware of. Sorry for anybody that I'm coughing into the microphone. I think what I can say about that is that just like every facet of human diversity, weight is going to follow along a normal distribution, right? So some people who live in larger bodies may be in a larger body for reasons that are not related to their genetic blueprint, such as medication or eating disorder, or some of the disparities, right? The social and systemic disparities that we see. We know that moms' access to adequate nutrition when baby is in the womb actually impacts then baby's metabolic function later in life. And again, those are survival adaptations. And sometimes people's set point, natural, healthy weight is at the higher end of the spectrum, right? And so if I'm talking to somebody, I'm always really curious about like, well, what are your self-care behavior? How do you nourish yourself? Do you have access to internal, we have these internal cues of hunger and fullness. We have biological mechanisms that really allow us to do this without a whole lot of thought. If we just allow ourselves to listen to them, I think we as a culture get so focused on doing things right, we forget that we actually have built-in mechanisms to do it without, it's like watching toddlers eat, right? They just know they're hungry, they're full, they know what they want only blueberries, now they only want cheese. It's like, okay. Yeah, they have a lot of clarity about that. I think that so when I'm assessing this with somebody, it's like, how attuned are they to their own body, or how much are their behaviors out of alignment with what actually would, really supports their health? And that's the place, that I go, maybe if their behaviors are very out of alignment with kind of what their natural signals would be, maybe there's an eating disorder, then that could change somebody's body size. But then it's like, okay, well, how do we help you come into alignment, right? So the focus becomes, how do we help you respond more accurately to signals? How do you have self-compassion? How do you give yourself permission to really find balance versus like, how do we make your body smaller so that it's where it's supposed to be? Does that answer your question?
Yeah.
Okay. All right, it's a good one. Okay, so the last assumption or premise of weight loss research that we're going to look at is this idea that losing weight makes people healthier. So let's see what we think about that. There was a group that actually tried to look at this a while back, and their study is called Long-Term Effects of Dieting. Is weight loss related to health? If anyone wants to look at the study, it's listed in the references. And basically what they did was they found a bunch of studies that looked at weight loss interventions and also certain biomarker like health outcomes. And what they found was that, first of all, the folks in the weight loss arms of the interventions didn't lose a whole lot more weight than the control folks anyway. And I think that's worth talking about because it's like, 3.3 pounds for all that effort. Like, you know what I mean? Is that going to actually change somebody's, experience in the world? But what they found and talked about in the study is that there were 3 confounding variables that they looked at, which were exercise, improved diet quality, right? These are independent variables that can impact both health and weight simultaneously or independently. Those kind of third sunshine variable, right? And then also social support, right? They had a lot of support when they were doing these studies, and that can be really, really impactful as well. And what they concluded was that, well, first of all, the health improvements that were found did not even necessarily correlate directly with the weight loss that was found. And any health improvements seen could have been accounted for by the behavior change, not necessarily the weight loss per se, right? And so I think that's what we're trying to do here is like, how do we, it's like uncoupling the behavior, right? The health supporting behavior from the change in body size. Conversely, I know plenty of people who've lost a lot of weight by smoking cigarettes and drinking coffee. It's like, okay, is that going to improve their health? I don't know. But they go to the doctor and get a lot of praise. So it's like, what are we doing here? This is another study that was done. This is based on NHANES data. I always forget what NHANES data stands for, but it's, does anyone know what NHANES is? Public health stuff. I don't even know if they're still doing it. Okay. It's what's good about it is they get a really big representative sample of the population and then just basically ask them like a bunch of health questions. And so these researchers took some NHANES data and asked the question, okay, so if we look at the relationship between health behaviors and mortality and body size, what do we find? And they found that when people are engaging in 0 of these health behaviors, so eating 5 or more fruits and vegetables daily, exercising, consuming alcohol in moderation, not binge drinking essentially, and then not smoking. When people engaged in 0 of those health promoting behaviors, there was a really big discrepancy across the weight spectrum, where folks who lived in, kind of the quote unquote normal BMI had a much lower risk of mortality than folks at the higher end of the spectrum. But what they found is that as they increased in the number of health behaviors that people were engaging in, that discrepancy disappeared until, the folks that seemed to be taking really good care of their health, even though they were in the, quote unquote obese category, still had about the same mortality risk as folks in the lower, the lower weight category. What is important to say about this is that this is still correlational data. I'm not here trying to be like, don't look at their correlational data, but this correlational data, we're gonna say it's causal, like, no. But I think what's important about this research and the outcome is that these researchers asked a different question, and so they were able to see something different, right? When they weren't making the assumption that being at a lower weight makes you healthier, then they asked, okay, well, how can we look at that a little bit closer? And they found something different. And so that really brings us to this idea, I think, kind of coming back to the title of this talk, which is, science, is it science or is it bias? Well, I would posit that science is always biased, right? We like to think that we can sort of like apply this objective scientific method and that somehow we're going to come out with some truth with a capital T, right? And, and I think also it might be a little bit easier when you're studying like, how antibiotics grow in a test tube, right? But when we're looking at human beings and human behavior and human health outcomes, right? Well, there's always going to be bias infused into that research. And so as you are going along in your careers or in your educational paths and you're coming across this research, some of the things you might want to ask yourself is, well, who's asking the questions, right? Are they people that have a certain perspective, that are invested in a certain worldview? What are the questions being asked? Where's funding coming from? That's always a big one, right? I mean, when people give a lot of money to something, we might be curious if they have some investment in what the outcome is. Who decides who gets funded, right? Like, there are so many studies on weight loss interventions, and there are not that many studies on weight inclusive health research. That's not an accident. It is almost nearly impossible to get funded for some of this stuff, right? And then finally, what pre-existing assumptions are going into the questions being asked, right? And we looked at 3 today. We looked at this assumption that obesity is a public health crisis. We looked at the assumption that safe and sustained weight loss is possible for the vast majority of people. And we looked at the assumption that weight loss leads to better health. And hopefully through this, and again, I'm not trying to prove anything. I think we can get into such black and white thinking about all of this, but I think we have to remain curious. And hopefully this just brought up some questions and, more questions and a critical lens to bring as you are engaging with the research. A few more notes before we move into the Ozempic part of the talk. I don't know how many of y'all plan to go into like clinical practice with like one-on-one or kind of, or more work on a systems level. But I am a clinical dietitian. I work one-on-one with individual clients. And I think it's also just so important to name that like we are talking about population level research, right? And so even the best scientific evidence is not, necessarily going to apply to the human being, right, sitting right in front of you. And so when we think about what evidence-based practice is, it also includes patient values, preferences, and lived experiences. And we really have to take the whole person into account. And also, clinical experience on the part of the clinician. I've been in this field for 10 years. And because I really listen to the people that I work with, I bring what I have learned into the space, and I do that unapologetically. And then I continue to really listen to the person who I'm sitting in front of. All right, so now that we've kind of covered that, I could have probably ended the talk there just a couple years ago, but now we have Wegovy and Ozempic and Mounjaro. Oh my. I saw the whiz like a week ago. Okay. Before I get into this, I want to like give a shout out and a resource for y'all. So does anyone listen to the Maintenance Phase podcast? Yeah. Okay. Well, I just did the this podcast is really amazing at doing a deep dive into some of the nuance, similar to what I tried to start talking about today when it comes to weight and health science. And like kind of fortuitously or serendipitously, they just put out an episode on Ozempic. So, and I listened to their bonus episode and they said they each did about 4 months of research individually to put the episode together. So it's a very well-researched episode. A lot goes into this topic. I'm gonna try to do it in like 20 minutes or less. So we're just gonna touch the tip of the iceberg. But if you want to know more, listen to that episode, listen to their whole podcast. Michael Hobbs is one of the hosts who did the, he used to be on the You're Wrong About podcast. That was a pretty popular podcast. And then Aubrey Gordon is a really incredible human being who is kind of in the fat activist space. And she used to go by the moniker Your Fat Friend and write anonymously, sort of just her experience of living in a larger body in the world. And then she has been, disclosed her identity. She's written 2 books and she does this podcast, and she's also in a documentary movie about her experience. So she's someone to watch. Anyway, so shout out for that. So I'm just going to scratch the surface here. So first of all, what are these GLP-1 agonist medications? So GLP-1 is a naturally occurring hormone. It regulates hunger in the body. It regulates the rate of gastric emptying. It also sends signals to the brain to communicate satiety to the brain, and so it can really regulate food intake. It also has some action on the pancreas to release insulin. So it's originally was designed to be a diabetes medication, and it's actually very, very effective at managing diabetes for a subset of people for whom other diabetes medications haven't worked. Not for everybody. In my clinical practice, I have had clients who have both had credible support from this medication in managing their diabetes when nothing else was working. I have also had clients who could not tolerate this medication and it did nothing for their blood sugar management. So it is not a miracle drug, but it does work very well for some people. It's really incredible the range of experiences that people are having with this medication. So there's a few different types of these GLP-1 agonists. Liraglutide, semaglutide, dulaglutide, tirzepatide. They're known as, Saxenda, Trulicity, Mounjaro, and then the big ones that we all hear about, Ozempic, and then it's, sibling medication, Wegovy. Wegovy is Ozempic, except it's just double the dose. Only Saxenda and Wegovy are FDA approved for weight loss. So have been studied for weight loss. All the other medications have been specifically are approved for diabetes management. Okay, so what do we know about these medications? And when it comes to weight loss. So if you go on the Ozempic website, they have done a series of 8 studies. They're called the STEP trials. Step 5 is the longest one. It was a duration of 2 years. And so we'll look at that. It's important to note that all of these studies were funded by Novo Nordisk, who is the company who is making bukus of dollars off this medication. I believe there have been some other independent research studies, but I have not had the chance to do like a deep dive into everything that's out there. So this study was 2 years in duration. 152 participants. It's not terrible. It's not a huge study group, or in the Wegovy arm. So there was also a control arm of similar study size. Something to really note is that over 90% of the participants were white. So very little diversity in that domain, and also a lot of exclusion criteria. And I actually printed out the part of the study that talked about all the different people who were excluded, right? So basically, if you had a previous or planned weight loss surgery, you could not be in the trial. If you had a history of major depressive disorder within the last 2 years, you were not in the trial. Diagnosis of other severe psychiatric disorder, not all of which were listed. They only listed they said, for example, schizophrenia or bipolar disorder. I don't know what other mental health diagnoses were excluded from the study, but they say nothing about eating disorders, which I think is really interesting. I have no idea if they screened or did not screen for eating disorders in this population. A lifetime history of a suicide attempt or suicidal ideation within the past 30 days. Or, this one makes me laugh, female who is pregnant, breastfeeding, or intended to become pregnant, or was a childbearing potential and not using a highly effective contraceptive method. So, and there are a lot of people who were not included in this study. And I can tell you, I think of the clients I know of mine who either have tried this medication or who were offered this medication and turned it down, absolutely had some of these criteria. And this was not screened for, in the doctor's office, or, true informed consent was not given around. Okay, well, here's the population that was studied. You have these things. So here's what we know and here's what we don't know. Those conversations are not happening in that 15-minute doctor's appointment. They're just not. Average weight loss was about 15%. Some people lost less, some people lost more. So this is the average. And what they also found in another one of the STEP trials was that when people went off the medication, even if they maintained, diet and exercise protocols, because that was also part of this, there was also these other lifestyle interventions that went along with it, they regained weight. So essentially, you have to be on this drug for life in order to maintain the weight loss. As ostensibly, also, we only have 2 years of data. So when you look at this, it's like, it's starting to go back up. What's going to happen after 10 years, even if you stay on the drug? We don't know. And I think that's the thing that I just want to this is a take home message, is we don't know. These are very new medications. I think Wegovy came on the market in 2017. It was only a couple years ago. No, excuse me. It was Ozempic came on the market in 2017. Wegovy was only a couple years ago. So, it's like, well, what's missing? No data beyond 2 years, but it's recommended for lifelong use. This has been more, since I put this, I did a talk on this a little bit ago, and just in the last couple months, more and more reports are coming out about gastroparesis, delayed stomach emptying. I think literally within the last few weeks, the FDA updated the warning label to include a risk of ileus. And ileus is when there is a complete intestinal blockage, and it is life-threatening. At least 2 deaths of ileus have been reported directly related to the use of these medications. Yeah, it's gnarly. And then I think, for me, well, who's assessing nutrition status, right? These folks are eating vastly reduced amounts of food. Probably the most comparable thing I can think of is what happens, with bariatric surgery. And we know that the amount of malnutrition and nutrient deficiencies that people get following those surgeries is just off the chain. And so nobody's looking at this. So someone's on this drug for 10 years, what's happening for their nutrition status, right? We don't know about the long-term health impacts. And for someone who has diabetes, right, who has uncontrolled blood sugars, it's a very different calculation than someone who's trying to lose weight but doesn't have any other, health risk. So.
Annie, will you explain gastroparesis? Because it's scarier than it sounds. It's worse than it sounds.
Yes, gastroparesis is a terrible thing. It is basically, it's technically slowed gastric emptying. I mean, in these, I pulled this from just the internet, but it's they're calling it stomach paralysis, in the media. I have a client who has gastroparesis who has to have a GJ tube. So she actually has her stomach really, her stomach emptying capacity is so slow, that when she eats, her food will be in her stomach hours and hours later. So she has a tube that goes through her stomach into her small intestine to bypass the stomach. And she gets the vast majority of her nutrition from tube feeding because she cannot, it's not fun. And I'll tell you, actually, I had a client who was on one of the GLP-1 meds. I can't remember which one. She had some horrible GI side effects. She had to stop eating salads altogether or she couldn't leave the house. It was really bad. But she had to get an endoscopy. And so she went and they told her, stop eating, you have to have an empty stomach for an endoscopy. And so it was a full 12 hours between when she had her last bite of food, when she went for an endoscopy, and she had to reschedule her endoscopy because she still had food in her stomach. Yeah, and then I have other clients who have none of those side effects. It's really interesting, and I don't think we know why. Again, there's so much about these medications that we don't know. I think the last thing, or one other thing I'll say about this is that, just mentioning the concept of health equity. So semaglutide is currently on the FDA database shortage list. It has been in shortage for a really long time. I don't know how long it's going to continue to be in shortage. I have had clients who every time they have to go, and one in particular who's having this, it's really helping her. She has to call multiple pharmacies every time she has to refill her prescription because they never know where it's going to be. There have been weeks she hasn't been able to get it. So people who really actually need this medication to save their life are not able to get it, in part because so many people are using it for weight loss. It's become so trendy, right? Right, and Ozempic is being prescribed off-label for weight loss when Wegovy is not available. And also, insurance only covers these medications under very specific conditions and very specific plans. Ozempic per month out of pocket is $900. Wegovy about $1,300. So who can even access these medications, right? Again, we're looking at these more systemic, access to resources kind of things.
To me, this almost seems like that when when they had that insulin shortage where where the prices got spiked, it seems like a different side of the same coin. Yeah, you want to be healthy, but you can only be healthy if you give us X amount. It's like another thing where our system's built that we'd rather treat diseases than be able to prevent them. So I think this is just a really good way for that to be exemplified.
Yeah, we don't have, capital, it's capitalism, right? These are money-making industries, and how do we sort of hold that and reconcile that with the fact that we're talking about whether humans live or die, whether they have access to certain medications, insulin for sure. That was terrifying. And so I was gonna say something else about that. Yeah. I don't know, I forgot what I was gonna say. They talk about this a lot on the podcast episode if you listen, but now compounding pharmacies are starting to make semaglutide, except there's basically a lot of stuff that people are buying that's not what it says it's supposed to be, and there's also this whole other level of that happening. And so when you go on and you see oh, this weight loss company, you can get your Wegovy for $250 a month. That's probably something that's being made in a compounding pharmacy, and whether that is actually semaglutide is probably not.
So obviously we can see that these drugs are being abused and misused. Do you think it's the physician is not prescribing it correctly, or there's different rules and regulations that are making it harder to figure out if that medication is actually right for them?
Yeah, so the question was for anybody at home, why are this being prescribed in the way that it is, and sort of maybe being misused? And that's the thing, it's would people say it's being misused, right? Because it's being touted as a weight loss medication. So I think people are going in and doctors are saying, hey, there's this great new weight loss medication. It's called Wegovy. Do you want to try it? I don't believe, what I don't think is happening is that true informed consent is being given in these circumstances. And so people are going in without knowing how little research has really been done, what the true risks are. I mean, there's black box warnings for thyroid cancer. People have gotten really bad pancreatitis. I mean, these are rare side effects, but they can happen. Okay, so the last thing, I keep checking, I'm doing good on time, yay. The last thing that I want to do, okay, is kind of talk about like this sort of impacts of like the discourse around all this, right? It's like, oh, like everyone in Hollywood's taking it, and it's like, oh, the Kardashians are taking it, right? Like and there's also been a lot of conversations about, oh my gosh, it's the new miracle drug, right? Is this the end of obesity, right? I mean, look at, we see this in the headlines, and it's like, what is the impact of that? What is the impact of how this medication is being discussed in the media? So I went to the podcast episode that Aubrey and Mike did, and I made a few edits just because it took a transcript. So I'm gonna read something that they say about this. Okay, so Mike said, to me, the most bizarre thing about the discourse since the results of these trials started coming out is the weird victory lap that people have been doing. It's like, okay, we know we have something now that works for weight loss. We finally have an effective weight loss drug. Now we have a cure for obesity. But even in the best possible version of these events, we're talking about a drug that 50% of people who take it will lose 15% of their body weight. And that is not a world without fat people. It's not going to end the obesity epidemic. It just isn't. We still, as a society, need to work on stigma against fat people, improving medical care for fat people. This is still true even if every single person in America loses 15% of their body weight. And Aubrey says, and that is a very dramatic, or she says that is a dramatic overestimation of what's even about to happen. As you say, even if they work exactly as they are projected to, even if the data doesn't change one bit with future trials, someone my size goes from being 330 pounds to being 280 pounds. That would take me from being a person with an obese BMI to a person with an obese BMI. So this whole thing about, is it the end of the obesity epidemic? A, no, it's not, as you pointed out. And B, that is the meanest freaking thing to say. It's really upsetting. And not just on an individual level, but also systemically. At the height of, and then she says, at the height of the bariatric surgery craze, I stopped seeing doctors for like 8 years. That really fueled how doctors would talk to me and what treatments they would offer me. And it was very frequent conversation of me being like, hey, I'm 24 and I have an entry-level position at a nonprofit where I feel fortunate to even have healthcare coverage at all. No, I don't have 25 grand for a weight loss surgery. But that still became a thing amongst healthcare providers who we already know are more likely to think of fat patients as non-compliant, as slovenly, as unattractive, as weak-willed, as all of these things. This becomes another reason for that group of people, healthcare providers, to stop listening to fat people. And then she says, it's going to get harder for me to get healthcare. That's part of what's about to happen. So like, this stuff has real life implications on human beings trying to navigate the world. And I think, for those of you who are going to be going into health communications and public health stuff, yeah, it's like to really be aware, right? That like there are human beings walking around that are being impacted by this messaging, and maybe some really unintended, but really deeply harmful impacts, right? From the way that we discuss size and bodies and weight in the, I think the public health space and the public kind of media space. There were two things I wanted to, just more examples I wanted to give just from my own clinical experience, because again, I think I get a window into this that others don't always. So I have a client right now who just, had all the terrible things growing up in terms of being put on diets and shamed for her body size. I mean, she was one of those people who was always meant to live in a larger body, and that was just not okay in her family system. She dieted her whole life, and eventually before I worked with her, went on to get bariatric surgery. As many people who get bariatric surgery do, regained quite a bit of the weight, and then came to work with me, and we were doing some absolutely beautiful work about body acceptance, and she was eating in a way that was really body attuned and just really I mean, stuff that was really, and then she said, I feel so much better. Well, this person has really bad knees. Her knees got to the point that they were bone on bone. She works with special needs kids and she's having to like hobble around with just like in horrific pain all the time. She was told that they will not operate on her knees until she loses, I think it was like 60 pounds. And so she is now in the process of starving herself to lose 60 pounds so she can have access to the knee replacements that she needs. I mean, I sat with her and we cried together. Like, but they're like, that is how gate kept, access to resources, based on body size are in the medical, in elements of medical. I don't want to paint, it's like, I don't want to paint the whole medical field as, and they're subject to, we try to figure out, well, why is this happening? Because insurance companies basically say, we're not going to insure you if you do surgery on clients of this size because we think they're more likely to, have post-surgery complications. So it's like, it's up the chain. So having a society that understands the impacts of fat phobia in medical care is critical for people's ability to access life-saving care. So anyway, I just wanted to share that story. And I think one other thing I want to say, and then I'll wrap it up, is that this doesn't just affect fat people. This affects people of all sizes. That I cannot tell you how many clients I've had with eating disorders who are in thinner bodies, who are quite literally starving to death. And doctors being like, what you doing? You look great. You're doing fabulous. Keep up the great work. And they're like, I've had clients who literally had bradycardia, which is a lowered heart rate, which is one of the earlier signs of malnutrition before people get really medically unstable with their eating disorders. And I have a doctor say, oh, well, you just must be really athletic. So you've got a really athletic heart, because you look so healthy. How could anything possibly be wrong? I've seen that in teens get missed and then all of a sudden they come to me and now they're like, basically, one foot in, on the brink of needing to go to the hospital because it's been missed for so long. So anyway, I have a lot of feels about all that. So I think the more that we can as a society understand all of this, and I think you guys are positioned to make a difference in the world around some of these topics. So I hope that this talk was impactful today. Maybe it brings up a lot of feelings, maybe there's curiosity, maybe there's, feeling pissed off, whatever. Whatever you're feeling, it's good, go with it. So yeah, that's all I got for today.
We have a few minutes for questions, Amy, if you don't mind. We have a few questions.
So if somebody was looking to work with you or work with someone of similar credentials, do you think you could maybe talk us through how you would start that process? Because it gets pretty overwhelming because everybody on social media gives health advice and everybody thinks that they're qualified to do this. And so like even our health insurance, like will cover this, and then you realize you're talking to somebody who is not a good match for you, but you don't even know the term to be looking up, like that kind of thing. So like what if somebody was like, I would like to work with you or someone like you, what would I Google to start that process?
Yeah.
Can you kind of repeat the questions? I can't figure out how to make this work.
No, that's okay. Yeah. So the question is, if somebody wanted to work with a dietitian who is of a similar orientation, the terms you would look for, like whether you're kind of Googling or look through on their website, would be health at every size, or HAES is sort of an acronym that has sort of become an umbrella for folks who practice through a weight inclusive lens. Terms like weight inclusivity, body liberation, maybe intuitive eating. Intuitive eating is like a model that was developed by two dietitians, I know maybe 20, 30 years ago. And there's a book called Intuitive Eating. That's quite good. it's become very trendy, and so I think some people who do more weight lossy stuff have sort of co-opted some of the intuitive eating language. You have to be careful and discerning, it's really hard. But if anybody is, you know, kind of saying, hey, let's eat intuitively so that you can, you know, lose the weight you want to lose, I mean, that would kind of be a red flag. I will say that, and this is something that's actually taken me quite a bit of time in my own kind of career trajectory, is like, I used to be really kind of like, oh, like kind of dogmatic about weight inclusive practice. And I mean, I still believe it in my core. But what I learned is that like, I can't show up in session and put that on my client. Like, I really hold space. If someone comes in and like, I really want to lose weight, like, we sit with that. And it's like, yeah, let's understand like what that's about. And, you know, that can be rooted in, you know, body-based trauma from childhood, just the trauma of living in such a horrifically fat-phobic world and being denied access to resources. So there's many reasons why people would want to lose weight. Obviously, like, it's hard to live in this world. So, I mean, finding a provider who's also willing to sort of, I think, sit with the complexity of it and not just say like, you have to come in here and agree with me about all this stuff, right? Versus like, oh, like, we can have a conversation about this, and can I offer you some information, you know, or some resources to dig into it a little more yourself. Any other questions or comments?
So I'm in gerontology, and we talk about how like extreme calorie restriction is the only way to like actually promote longevity.
But so you're like meaning like working with older people?
Yeah.
Okay. Yeah. That probably is very different than what you heard today.
Which is like ironic because like so many people, like the main cause of death is like dehydration and like malnutrition, like people are dying, you know, so like how.
Frail old people in the hospital. I mean, there is actual research on this. You are more likely to die in the hospital if you are thinner than if you are at a higher body weight. That's just fact. Yeah.
So I was wondering, as a dietitian, like I mean, obviously, I think it's great to put all these qualifiers around, you know, large body size, but there has been like an increase in our body sizes since the 1980s. And oftentimes there's also increase in like heart disease and increase in diabetes. And so what do you attribute this to?
Well, I think that there are so many confounding variables. I can't possibly, you know, say, but I will say this, we have been focusing really hard on the war on obesity for the past 20 years. And that doesn't seem to be doing much to make anybody healthier. And I also think that we have seen an incredible spike in social inequity in that same time frame. So if I had to posit a guess, it would be something around that.
We also, since the 80s, have gotten better at detecting heart disease in women. So it's being diagnosed more because we know how to detect it more, not because it's happening more often. It's just women were dying more often of heart disease before the push to figure out what it looks like in women, which was in the 80s.
So is it about that these things are actually, and that's when with a lot of health conditions, that's been the case. Are we just diagnosing more versus is it actually happening more? Thank you. Yeah.
So there's a lot of different food and ingredient regulations in the United States than compared to other countries. Do you think that some of the harmful ingredients that the US puts in some of their foods attributes to the weight gain that we've seen over the past few years,
I mean, I have no idea. Yeah, I don't know. I mean, certainly there can be like endocrine disruptors. I mean, I don't want to discount the possibility of that. I think that probably the answer is, it's really, really, really multifactorial. But I will say, what I observe is that, and this goes into the work that I do. I work from a very somatically oriented framework. So I look a lot at how the way like our autonomic nervous system is functioning and everything impacts like how we're able to sort of embody our capacity to sort of eat intuitively, eat, you know, from a place of you know, really, you know, knowing what we want and need. And I think that as a society, we have become so disconnected from our own bodies. I think that we are very disconnected from each other. I think there's a lot of social isolation. I think social media has not done us any services in that particular domain. And the more dysregulated people become, the less they're able to inhabit their bodies in a way that supports their ability to eat well. And so I just don't think that to me is really where I focus, because it's just so blatant. And then when people do become more regulated, they become safer in their bodies, they become more connected, it really changes how they're able to nourish themselves well. So I don't know if that answered your question, but it's the perspective that I've got.